Hey everyone, my name is Marisa Guzman, and today I will be presenting on childhood anxiety disorders. So there's a couple things that we're going to be looking for when it comes to defining a childhood anxiety disorder. The first is that the fear or the worry is not characteristic of the child's developmental level. So, for example, it would not be uncommon for a 2 or 3-year-old to really have a difficult time separating from their mom or dad. But when you see the same behavior in a 12 or 13-year-old, then that might signal that it's a deeper issue. The other thing that we're going to be looking for is that the worry or the fear is excessive and it's interfering with the child's life. So it's having an impact on their academics, on their ability to participate in activities, and socially with their peers. The other thing, just for your frame of reference, is even though they're called childhood anxiety disorders, we're really looking at the ages between 5 and 18. So that way you just have that for your frame of reference. So now that we have a definition of what childhood anxiety disorders are, we can get into the causes. What causes a child to obtain such a disorder? So there's actually a lot of different reasons of why an anxiety disorder could come on. And it really is kind of complex. And so, as we get into like how do you identify a disorder, you really have to peel back the different layers and find the reason that's most salient for the individual. So the first reason could be genetics. A child who has a family member with a disorder is more likely to have one. Kids can also inherit genes that make them more prone to anxiety. Brain chemistry can be a reason for these disorders. If there's specific brain chemicals that are not working well or that are in short supply, it can cause anxiety to increase in an individual. Different life situations that students encounter can impact their susceptibility to getting a disorder. And so, if a child has a very stressful life or has a very inconsistent life, if they experience the death of a loved one or domestic violence in the home, that can also cause kids to become anxious or for a disorder to develop. And the final cause would be learned behavior. So for individuals that are growing up in a family where they're maybe seeing parents or loved ones or siblings that are just inherently fearful or anxious of different things, it can kind of teach the child to be afraid or anxious as well. So there are 6 different types of anxiety disorders. Generalized anxiety disorder sometimes is abbreviated as GAD or GAD. Panic disorder, separation anxiety disorder, which is sometimes abbreviated as SAD, SAD, social anxiety disorder, selective mutism, and specific phobias. So generalized anxiety disorder is just like it sounds. It is an excessive worrying or sentiment of fearfulness about a variety of different things, such as academics, family issues, relationships with peers, performance in activities or school, social issues, etc. So it's just a general feeling of worry and anxiety about lots of different things. When we're looking at who is affected, 1% of children and 3% of adolescents are impacted by GAD. And what does it look like specifically in the classroom? So students with generalized anxiety disorder tend to look like perfectionists or overachievers. Not always, but a lot of times they do. And they often are seem to be very organized, very high achieving on the outside, but under the surface there's a lot of worry, a lot of fear that they are experiencing. These students are often very hard on themselves if they fail or if they make what they perceive to be an error or a mistake, and they constantly seek approval or reassurance from teachers, peers, parents, coaches, etc. Next, we'll look at panic disorders. So with panic or anxiety disorders, we're looking at a sudden state of distress that comes on suddenly and unexpected, and sometimes for no detectable reason. Who is affected by panic disorders? 1 to 3% of children and adolescents experience panic attacks. They're typically more common in adolescents, with about it affecting 2.3% of the adolescent population. If you look at the graph to the side here, we can see kind of a breakdown of panic disorders among adolescents. They tend to be more common in females, and they tend to be more common in adolescents that are older, on the older end of the spectrum. So what does that look like if a student is having a panic attack? Typically, they're going to show visible signs of distress. They might be sweating or shaking, they might have shortness of breath and a rapid heartbeat. They may also be experiencing chills or hot flashes, and typically all of that physical distress is going to be accompanied with an internal sense of loss of control. They might have an overwhelming fear of death and despair, and just have an overall feeling of a dread as this is occurring. Next, we're going to look at separation anxiety disorder. So as I mentioned a little bit earlier, separation anxiety is normal when it is experienced by a younger individual, typically a child between the ages of 18 months and 3 years old. That is something that is a typical part of that developmental process within that age group. However, when separation anxiety is exhibited by older children, that's when there's definitely something that needs to be addressed. And so what separation anxiety looks like is the inability to separate from family or caregivers. In the event of a separation, a child may have a difficult time recovering. So what recovery means is just being able to kind of recover from that separation, be able to refocus and re-engage in the classroom environment. It is often accompanied with a sense of misery or homesickness when a separation occurs, and the way it manifests is that this child may refuse to attend school, activities, camps, sleepovers, which tends to have an impact on their social development, and they may even demand that a caregiver stay with them at night. So who is affected by separation anxiety? We see this in 4% of children, typically between the ages of 7 and 9, and it can develop after a trauma. So what might this look like in the classroom? A student that has total meltdowns every morning at school during drop-offs, and who requires excessive time to cool down afterward may be experiencing a separation anxiety. And so if we're looking at a student that has meltdowns, typically the student has been going to school for a while, so they know the routine, they know what's going to happen, but still they're having a very difficult time with that separation, and then they're having a difficult time refocusing and being able to engage in the school environment. It might also look like a child who does everything that she can to prevent herself from falling asleep. So children that are experiencing separation anxiety might interpret sleep as a separation from their caregivers, and that might create a frustration with that child. Social anxiety disorder is characterized as an intense fear of social and performance situations and activities. Individuals that suffer from social anxiety have a very difficult time often communicating or getting their points across. They might think of having interactions with peers or others as something that is very uncomfortable, and they might ruminate over how the day went or how interactions went, and they would be fearful of that they came across in a way that was unappealing to others. Social anxiety disorder is the second most diagnosed anxiety disorder following specific phobias of the 6 that we are discussing today. Many individuals who have social anxiety disorder report having extreme shyness as children, but it is important to note that shyness and social anxiety disorder are 2 completely different things. The disorder really impacts an individual's ability to complete day-to-day tasks, and it becomes much more burdensome than your average shyness. It's important to note that social anxiety disorder is on the rise in the United States, and some attribute that to the pandemic, with individuals, especially our youth, being isolated during key developmental time frames where they should have been interacting with peers and developing those social skills. It all kind of came to a halt as they were isolated in their homes. A lot of the research regarding the pandemic and social anxiety disorder is pretty new, so I didn't include it in here, but it is definitely important to at least have that conversation, especially since many of us will be working with children and adolescents who were impacted by the pandemic during their developmental years. So who's affected by social anxiety? 3 to 6.8% of younger children will have this disorder, with slightly higher levels in the adolescent population. The typical onset of social anxiety is about 13 years old, but it can also be seen in younger students. So what might this look like in a school setting? For example, a high school student might refrain from interacting with his peers throughout the day and can be seen with headphones in his ears whenever possible. During small group work, the student is visibly uncomfortable and may only respond with 1 or 2 words or head nods. Selective mutism is the refusal to speak in situations where talking is expected and necessary. So an individual with selective mutism is going to not speak. They may turn away or stand motionless or expressionless when people are trying to engage with them. They may avoid eye contact, and they may just kind of turn their whole bodies away from the person who is trying to engage with them. The interesting thing about selective mutism is that individuals who are exhibiting this kind of behavior typically are normal or have normal engagement in terms of talking in places where they feel comfortable, like at home or with caregivers, and they're only selecting not to speak in a certain environment. So who is affected? Less than 1% of children in the United States are affected by selective mutism, and that percentage could be a little bit off, as often selective mutism is misdiagnosed or thought to be a characteristic of a different disorder. The onset of selective mutism is typically around age 5. And so what might this look like in the classroom? So, for example, a kindergarten student has been refusing to speak or engage with her classroom environment, even though she has been in school for about 2 months now. Her parents are surprised because she is typically very talkative and exhibits normal behavior at home. Specific phobias are intense and irrational fears of a specific object, such as a dog, or a situation, like swimming. There are 5 different types of specific phobias: natural and environmental, injury, animal, situational, and other. Essentially, with specific phobias, a child or a person is very, very fearful of something, even if that object or situation is not currently present or immediate in their lives. So who is affected? 7 to 9% of children, 13 to 18% of adolescents, and it is the most common anxiety disorder of the 6 that we are reviewing today. So children with specific phobias may do a number of things to avoid the situation or the thing that they fear. They might cry, they might have tantrums, they cling to their parents, or they'll try to avoid the thing that is making them fearful. And the phobias and the sentiments of fear actually create physical symptoms of discomfort, such as headaches and stomach aches. So what might this look like in the classroom? A 10-year-old student has a phobia of thunderstorms. This phobia becomes particularly challenging during the late summer and spring months, when storms often occur during school. The student screams, cries, and hides under her desk when she hears thunder, which can be very disruptive to her peers. So now that we have a foundation in the 6 different anxiety disorders, we are going to look at diagnostic criteria. So for generalized anxiety disorder, we're really looking at excessive worrying or anxiety for more days than not for at least 6 months. We want to see that there are significant impacts and impairment in an individual's ability to do basic functioning, like going to school, activities, or doing an after-school job. An individual would need to have an inability to control their worrying, and at least 6 of the following symptoms would need to be accompanied with what has already been discussed. So restlessness or feeling on edge, being easily fatigued, having difficulty concentrating, irritability, muscle tension, and sleep disturbance. In addition, in order to diagnose generalized anxiety disorder, it cannot be better described by a different mental disorder or substance abuse. So it would have to be we would have to rule out those other things before we could make a diagnosis. So the big things that we're going to be looking for in a panic disorder diagnosis is that an attack is occurring more than once. Most people throughout their lives are going to have at least one instance where they might have something occur that is similar to what we would consider a panic attack. Now, if this is occurring more than once, then we might want to look into making a diagnosis. In addition to multiple occurrences, a panic disorder is diagnosed if it is followed by at least 1 month of persistent concern that it may occur again. So the individual that just experienced the attack is being very, very fearful and concerned that they may have another attack. In addition, the individual may adapt maladaptive behaviors to avoid another attack. For example, if it happened at school, they may refuse to go to school or engage in those certain activities. And again, it's very important that we're looking at all the other disorders and ruling out that they could have been an impetus for the attack. A clinician that is making a diagnosis for separation anxiety is going to look for symptoms that are excessive for the child's developmental age and that are impeding their daily functioning. A clinician would often use a structured interview that involves discussing thoughts, feelings, and they may do a direct observation of the child's behavior to make a diagnosis. To make a social anxiety diagnosis, there's going to be a physical examination to determine if there's anything medical that is creating the symptoms of anxiety. After that is ruled out, there will be a discussion of the symptoms and how often they occur and in what situations. A list of situations might be reviewed to see if it makes the child anxious, and the child may participate in a self-reporting questionnaire about symptoms of the anxiety that they experience. And ultimately, a decision will be made based on the DSM-5 and the criteria that is listed there. In order to make a diagnosis regarding selective mutism, we'll need to take the following into account. The child needs to demonstrate a consistent failure to speak in certain situations, but not in others, such as being able to speak at home, but not at school. The symptoms must have been present for at least 1 month, and not simply at the start of a new event, such as the first day of school. The child must understand spoken language and have the ability to speak normally in some situations. We're looking to make sure that the child is not experiencing a speech impediment or a speech delay in their development. In addition, the lack of speech must interfere with the child's educational or social functioning. It is important to note that children who stop talking after moving to a new country or experiencing a traumatic event would not be considered a candidate for selective mutism and would not receive that diagnosis. To make a specific phobia diagnosis, a clinician would want to consult the DSM-5 criteria, and the following must be present: an unreasonable and excessive fear of a situation or object, and there must be an immediate anxiety response when exposed to the object or the situation. There would be avoidance or extreme distress by the individual in order to get away, or they would just break down at the sight of the object or situation, and it would be life-limiting, having a significant impact on the individual and their ability to function. The phobia would need to be in place for at least 6 months in duration and not be caused by another disorder such as OCD or agoraphobia, for example. Now that we've gone over how a diagnosis would take place for the different anxiety disorders, I would like to go into interventions. So how do we actually go and help individuals who are suffering from these different disorders have happier and healthier lives? So one way would be through psychotherapy. There are a couple different ways that we can do psychotherapy. The most popular that came up in my research again and again was cognitive behavioral therapy. Acceptance and commitment therapy is another one that would fall under the psychotherapy category. Stress management and mindfulness techniques would be helpful for a variety of the different disorders, although not all of them. Support groups for individuals to recognize that perhaps they're not the only one who has this issue or challenge, and be able to find different ways to cope with these different disorders. Medication would be another intervention if deemed appropriate. Antidepressants, anti-anxiety meds, and beta blockers are the most common forms of medication that are implemented for anxiety disorders. And exposure therapy for specific phobia, but also for social anxiety disorder, exposure therapy may help. So in the interest of time, I've chosen cognitive behavioral therapy to really delve into as an intervention method because it does come up so often for all the different anxiety disorders as being, and it's something that we can definitely apply in our different roles as counselors or teachers because it's so diverse. So cognitive behavioral therapy emphasizes the link between our thoughts, emotions, and behaviors. The core concepts with cognitive behavioral therapy are to really address an individual's unhelpful ways of thinking and teaching them ways to kind of stop the thought process and to incorporate more healthy and positive ways of thinking of different things. To address learned patterns of behavior by actively choosing different actions, and to implement management and coping strategies with the different issues that come up with our anxiety disorders. And so some of the techniques that are implemented via cognitive behavioral therapy would be SMART goals, which a lot of people are familiar with. They're just goals that are measurable, specific. They have specific time frames in which they need to be accomplished, and they can be easily implemented with students. Guided discovery and questioning is another technique. Journaling, self-talk, which would be being aware of the way we talk to ourselves and being kinder in the way that we address ourselves. Cognitive restructuring, so kind of thinking about a situation, and if it's very negative in our minds, maybe we can see it from, we can teach ourselves to see it from a more positive light. Thought recording, positive activities, and situation exposure. So again, exposing ourselves to the things that are most difficult. So if I am suffering from social anxiety disorder and I'm having a difficult time engaging with others, having conversations with my peers and slowly exposing myself to that would be situational therapy. In a 2018 long-term effectiveness study of CBT, so cognitive behavioral therapy, it's shown that more than half of the participants that had met the criteria for an anxiety disorder at a follow-up, which took place 2 years later, had promising results, basically indicating that they had severely reduced their anxiety behaviors or completely eliminated them. So now that we have a bit of a foundation in anxiety disorders, I wanted to talk about briefly how we can incorporate interventions into our overall school environment to help either lessen anxiety or give students tools to encounter anxiety in a healthier way. So a Tier 1 intervention might be to incorporate different strategies into our overall social-emotional school curriculum. So for example, this might look like going into a classroom and developing a stress management plan or doing mindfulness exercises with students. And so these skills and these topics might not be reaching an individual who is currently experiencing an anxiety disorder or anxiety in general, but if they do encounter it, they already have the skills to be able to manage it better. A Tier 2 intervention would be a support group that focuses on anxiety. So perhaps a counselor could lead a group of students that identifies as having anxiety from time to time, and maybe they are not diagnosed with a disorder, but they do experience these feelings, and so they can kind of talk that out and work on different coping skills and ways to minimize that anxiety. A Tier 3 level intervention would be with an individual who has a diagnosis, and maybe there would be check-ins and a success plan with a counselor to see how the student is doing, to see how they're progressing. You might want to use like the SMART goal technique for a Tier 3 intervention, so that the student is really focusing on specific goals to help incorporate either more interaction with others, or if they're having difficulties with a phobia, maybe the goal is to have more exposure that semester. So just a few final thoughts as I wrap up my presentation. One thing that came up again and again is that depression and obsessive compulsive disorder, or OCD, are often combined or intertwined with anxiety. And so if we are trying to address an anxiety disorder, it's important that we first determine that yes, it is indeed an anxiety disorder, and then to see if it is accompanied with another disorder such as depression or OCD, and then to ensure that we are implementing interventions that are not only addressing anxiety, but may also address the depression or the OCD if it's also present. Another thought that I wanted to share with you all is that it's quite fascinating how anxiety and many of the symptoms that were discussed today are a natural part of the developmental process, depending on where an individual is. And it really kind of is interesting how once these symptoms or these actions are accompanying an individual past a certain age, then it can really become a problem. But it is interesting how it is part of our developmental process as well. And anxiety can look like a lot of other things. So it's very important that we are going through our diagnostic criteria, working with a school psychologist if they're available, to really make sure that it is that we know what we're looking at is indeed an anxiety disorder. And depending on what an individual is experiencing at home or outside of school, that can make them show signs of anxiety that maybe isn't a full-blown disorder, but they might be symptomatic of something else that's going on. And finally, anxiety is definitely on the rise in our schools, in our community, and so it is important to be aware of all the different disorders and how they may impact all of us. And so just having that overall awareness, I think, was super helpful for me as I was putting this presentation together, and I hope you all found that it will be helpful to you as well.